Okay, should we get going then? Great. So, so today's our first kind of part on cultural humility, formulation, and mental health equity. And because I think not all of you guys have been to the whole curriculum, I added a few things that I thought was important that we cover with the other classes, especially for those of you who've never participated. Some of the fours I think have never been. And then we're going to do particularly formulation today. And then next week, Dr. Taylor-Desir is going to cover more on mental health equity and microaggressions. But if anything comes to mind, any questions, any comments, just feel free to interrupt at any time. I also sent you guys some kind of information, and particularly the interview, kind of the DSM information is good to have it handy because it has a lot of information and it might be easier to follow, especially with the cases. So for today, we just want to be fully present. Speak for yourself and not others. Be aware of your own hot buttons. Assume curiosity and positive intent. Refrain from negative and dismissive language. Respect all perspectives. This is a judgment-free zone. And then some topics that we're going to cover can make you feel uncomfortable. Some people will describe feelings of guilt or resentment, and that's kind of part of the process. And then we want to encourage you to ask questions. So I just came across this article today, and I wanted to point it out because it's this group at Yale who wanted to evaluate kind of the patient's perspectives on providers' cultural competence. And I think, and kind of the conclusion of that is that patients from underrepresented groups care and feel like having a culturally competent or someone who is culturally sensitive, I would say, matters to their care, and they want that from their providers. So I thought it was pretty relevant, and I think it is an important topic that's going to be growing, and so getting more used to learning and being part of this process, I think, is important in our practice. So a little bit on social determinants of health. You all in EPIC will see the little chart for social determinants, but we often don't really pay too much attention to that. But it's really important as we see and formulate our patients. So these are defined as the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect the wide range of health functioning and quality of life, outcomes, and risks. And as we think about social determinants of health, we have to think about how context matters. So if we are going to see a patient and we're going to make a recommendation or make a prescription, and we oftentimes do that like you need to maybe exercise or take some time of your day and deep breathe or relax, or we really have to think that that's not possible for some patients. Some patients don't have a safe space to be alone, or even as a space to relax. Some people don't even have the safety to leave their homes to do some exercise outdoors, or maybe the outdoors is polluted and that is a good space for them to exercise. Others have 2 jobs and three children, or they're single mothers, that they don't have time to sit down and do some mindful eating because that is not a thing. So I think as we look at patients, I think we have to really be considering all of these aspects because that's going to help actually adherence and treatment success. And I think intersectionality really is a concept that we have to always keep in mind. And we'll let Kimberly Crenshaw, who actually coined this term, tell us a little bit about it. Oh, let me see. Oh yeah, it worked. Let me know if it works. Ooh.
No sound, Laura. No sound.
Oh, well, why is that? Well,
I think if you stop screen share and then restart it again and click the optimize for sound sharing button, it should work.
Which one?
Like you have to stop in the Zoom screen share. You have to stop sharing.
Oh, well, we'll do it for the important ones. This one, well, I like how she describes it, but it's what it's written there. So we can skip this one and then try it for the next ones. So it's just a metaphor for understanding the ways that multiple forms of inequality or disadvantage compound themselves, and they create obstacles that often are not understood within conventional ways of thinking about anti-racism or feminism or whatever social justice advocacy structures we have. So when we think about seeing people, and it is not the same to just, for example, be a Latinx person, but if you're Latinx and woman, and also that person, for example, has a disability, all of those things will add up and mean different things. And so it is very important to keep in mind the concept of intersectionality and to see our patients in that way, to see how those aspects overlap and impact each life. Is the word? Okay. Oh boy. Okay. Then cultural and linguistic competence. So Dr. Liu actually came to give ground rounds here in 2019. He's done a lot of work on this topic, and he defines this as the ability of healthcare providers and organizations to understand and respond effectively to the cultural and language needs brought by the patient to the healthcare encounter. And I would say that competency, you'll hear a lot the term, and it's part of the process, but it's really not enough. Sometimes people will think that you'll get competent or gain some skills and you'll be done with it, or learn a few, aspects of a culture, which sometimes become more stereotypes than anything else, and then move on. And that's really not what we want you to kind of get from this. But this is a part of it. And sometimes even if they use competence as a word, I think some of the content or the material you'll get from that is valuable. It's certainly a developmental process for both individuals and institutions. And then the other part that's important that comes with this is linguistic competency, which is the capacity of individuals or institutions to communicate effectively at every point of contact. So we have to be able to convey information no matter what, even if there's no English proficiency, if patients are illiterate, if they cannot write or read, we have to be able, or speak another language, to communicate everything that we want to share to a patient. And sometimes that gets lacking. And there's a whole lot of information about interpreters, because I think that's more complex than not. So I think this is always important to keep in mind. But I really want from kind of that basic idea of competence to move into cultural humility, because I do think this is really important, which is the ability to maintain an interpersonal stand that is other-oriented or open in relation to aspects of cultural identity that are most important to the patient. And there are a few aspects of that I think are important. A personal lifelong commitment to self-evaluation and self-critique. And I think this is probably the most important part of the process. Also is the most challenging. A recognition of power dynamics and imbalances that hopefully could lead us to developing partnerships with people and groups, and then creating institutional accountability, and then always keeping in mind the historical awareness, which is very important. And all of that to kind of lead us to an important concept that's called structural competency. So actually Metzel and colleagues, they have this good paper about structural competency, and we'll go over the definition in a minute, but they actually think that this has to be incorporated in medical school education and sort of be part of the way we train and develop as physicians. And I think it's important. So they define it as a trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases also represent the downstream implications of a number of upstream decisions about such matters as healthcare and food delivery systems, zoning laws, urban and rural infrastructures, medicalization, or even about the very definitions of illness and health. So when we start thinking about how, the bigger systems and the structures really have an impact on all that kind of, I would say, illness, process, experience, and development, I think the way we approach certain circumstances and patients is different. And actually accounting that when we talk to a patient, I think matters. And things like, for example, discrimination and systemic racism, what we oftentimes don't think about when we see a patient, may be important to address with a patient, because that might change the way we care for that person and the way we relate to that person, which is so important for us because we want them to be successful with treatment. And the last concept that I wanted to talk about before getting into specifics of formulation is privilege, because I think this is a really important piece also of that kind of self-reflection and critique, is to start thinking about our own kind of areas of privilege. I sent you guys a paper by Peggy McIntosh that I recommend reading. I think she's done phenomenal work on this. And I think the way she started her own reflection it might be a good start for each and one of you. So now I have to stop sharing. And then how do you guys see the video?
Then you click share again, and then there's a little checkbox at the bottom that says optimize for.
Technology is hard, you know. Let's see. Oh, yeah, you go. Okay, can you see it now?
You can see it.
Some people are born into families where they have to walk miles just to get water. All I have to do is turn on a faucet. That's privilege.
Oops. Oops. There you go. Oh. I apologize.
If you have ever tried to change your speech, if you were embarrassed about your clothes or house, if you would never think twice about calling the police when trouble.
I think privilege is when some people have some things and other people don't have things.
I feel privilege is something that you don't even really have control over.
I think it'd be silly for me to say I don't have a fair amount of privilege, considering like the country I live in and the job I get to do and the college I was allowed to go to.
I suppose being a white male will help me end up somewhere towards the front, but I'll take a few steps back from being gay.
I don't think I'll make it to the front. I think I'll maybe be in the middle. That's just the gut feeling I have.
If your parents work nights and weekends to support your family, take one step back. If you can show affection for your romantic partner in public without fear of ridicule or violence, take one step forward. If you were embarrassed about your clothes or house while growing up, take one step back. If you have ever been diagnosed as having a physical or mental illness or disability, take one step back. If you have ever been bullied or made fun of based on something you can't change, take one step back. If you get time off for your religious holidays, take one step forward. If you came from a supportive family environment, if you can see a doctor whenever you feel the need, if you are able to move through the world without fear of sexual assault, if you took out loans for your education, if there were more than 50 books in your house growing up. So these are your final positions.
Okay, so, and now I cannot see anybody. Can you hear me?
Yes, we can hear
Oh,
you.
great, thank you.
I think it.
So I think it's pretty powerful, and I think it's a good place to start when we think about privilege, and then kind of built into this kind of self-critique and self-reflection. So a few things that I found that could be helpful for that. So things that you have to keep in mind when you think about that beginning of cultural humility practice. So define your own cultural identity. How do ethnicity, age, family experience, education, socioeconomic status, gender, sexual orientation, religion, etc., can impact interaction with your patients? A lot of places will call them clients these days, and I just refuse to do that. Become aware, right? What are your personal biases, assumptions about people who are different? Challenge yourself. How are your values different from other people, and how might your values not be the norm? Engage in that personal reflection. Remember a time when you became aware of being different from other people and how you dealt with it. Perhaps you were visiting another country, didn't speak or read the language. How did you manage? Ask yourself questions about after meetings. What assumptions did you make? What are you curious about? And then identify challenges. Identify those challenges you experience by taking cultural humility perspectives and supporting health literacy. Reflect and challenge of adopting a cultural humility perspective and supporting health literacy. How can you learn and grow from each experience? And then the Mayo actually has the Mayo My Learning area, which we often don't think about as a great resource, but it actually developed this module called Restorative Reflections. And this is added in the resources pamphlet that I sent to you guys. But I found that well done and includes really good topics, from exploring your sensitivity to other cultures, understanding biases, challenging your assumptions, getting in touch with your values and bringing it all together, and might be a good way to start thinking about all of this. Any questions about any of the things I covered before we get into kind of the difficult one? I will assume there's no questions. So I thought this was really interesting and important. So actually culturally kind of sensitive practices is so important, and there are actually places and hospitals that have developed a cross-cultural consultation team. McGill has done amazing work and a lot of work on this. And then there is a hospital in Geneva who also developed a cross-cultural consultation team. And physicians can make referrals to the team to help with consultations of patients from different backgrounds and different cultures that they think might need additional support. And the team will assess them in the process of caring for these patients, and the outcomes have been really, really good. They also are helpful in providing resources and helping, tailor care for that particular culture, which I also think is very helpful. Sometimes we find ourselves trying to find resources and helping patients when there's not much available, and ultimately we give patients sometimes treatment recommendations and resources that are not going to be helpful for them. So let's talk a little bit about the history. And as we go through all this topic, it's a lot of kind of dense information, but one of the things that I want you to think about is, despite the DSM having a lot of downsides in my personal opinion, but a lot of maybe not a place where sometimes we go and look and read, I think the cultural formulation and the cultural information in the DSM is a good resource to have. And I didn't know about it when I was starting residency, but I think it would have been very helpful to have and to learn about it. So I wanted to keep in mind that you have this. If you ever have a patient that's challenging, or if you ever need to have more ideas of how to talk about a difficult topic, I think this is a really good resource. So what's the history of this? So there was some topics about cultural insensitivity from DSM-3 to DSM-3R, and that led to the National Institute of Mental Health to support the creation of the group on culture and diagnosis in '91. And they initially thought about adding a sixth cultural axis, but they abandoned this because they thought this was not going to be helpful. And I'm so glad that it didn't happen, because I think this could actually lead to some I think stereotyping if you're not careful about it. Based on prior work, and this is all based on prior work on mini clinical ethnography, looking at kind of brief assessments of cultural factors that could be relevant to a clinical situation. Then in DSM-4, there was more the conversation about the cultural formulation model, which was a biopsychosocial approach, kind of highlighting the effect of culture on patient symptoms, explanatory models of illness, health-seeking preferences and outcomes. And this really led to the outline for cultural formulation. And you can see on the table on the right, kind of the kind of four, well, it's actually 5 main areas of that outline for cultural formulation. And we'll go a look at those. So the first part has cultural identity. So those things that include characteristics shared by person's cultural group, race, ethnicity, country of origin, language use, religious beliefs, socioeconomic status, migration history, experience of acculturation, degree of affiliation with the individual's group of origin. Then it's the cultural explanation of individual illness. And we'll talk a little bit more about some of the explanatory models, but includes the idioms of distress, how people experience and express distress, the definition about the sick role or behavior patient assumes, and patient's beliefs about prognosis and treatment options, the conceptual differences in the illness model between patient, clinician, and family. And I think this is important because when I was being part of a workshop for Somali population, there was this primary care provider who's seen a lot of Somali women. And she was saying, if you ever mention the word depression or any other psychiatric condition to these patients, they will never come back to you. They don't want to hear about it. They don't want to share that with their families or their communities. And they don't want to really, they don't think that's a thing. So you have to learn from the patient how they kind of define and identify illness so you can work with them. And then the cultural factors related to psychosocial environments and levels of functioning. And that includes family dynamics, definition of what constitutes a family and roles of individuals in the family, which varies across cultures. Patient's life experience of racial and ethnic discrimination. I think this is so important. Immigrants and refugees, the perception of openness if host society towards people of their country or region, and the identification of communal sources of support. And I think the family dynamics and the roles are a big part of it. When I starting to care for, she was over 90, 85 or 90 years old, Mexican lady who comes, she's brought to the US by her children. Her children passed away and she was put in a nursing home. And they made a referral because she was feeling depressed. And when you start looking at this, it was not a huge surprise because this grandmother, for some of the Latinx cultures and communities, they're very respected. They're people who the family will care for. We rarely think about nursing homes. They often are kind of the center of attention. They know how to cook. They know how to host. Families is around them. And this lady was left in a nursing home with only English speakers. She didn't speak any English. She was not allowed to play music too loud, which she really liked to do. She had no way of connecting with her granddaughter often, and her roles in life, which was to care for her family and be kind of that center piece, got totally lost. So I think that's really important to think about. And then the cultural features of this relationship between individual and clinician. So cultural identity of clinical and mental health team and how that impacts patients. Clinicians who have better understanding of cultural identity tend to care better, have kind of better patient care, and be able to anticipate cultural dynamics. Clinicians need to examine their own assumptions about other cultures, and then the therapeutic relationship, which we'll talk about, the role of some of the assessment tools and the interpreters, and then the overall cultural assessment, sort of the appropriateness of healthcare and social services, and the interventions that are needed. And in the explanatory models, there are kind of different models describe the moral, the religious, the magical or supernatural, the medical, and the psychosocial. But I really wanted to talk about the Arthur Kleinman explanatory model, because there's some questions that I think will be very helpful in an interview. So what do you call your illness? What name does it have? What do you think has caused the illness? Why and when did it start? What do you think the illness does? How does it work? How severe is it? Will it have a short or long course? What kind of treatment do you think the patient should receive? What are the most important results you hope she or he receives for this treatment? What are the chief problems the illness has caused, and what do you fear most about the illness? And I think as we get this information, I think it will be better to understand and start learning about some of the cultural differences of ways people experience illness. So depression, for example, in some cultures have a lot of somatic components and sensitivity, while others have more hopelessness and suicidality. So I think starting to understand those differences help. And then in terms of the therapeutic relationship, and this is mostly particular for therapy, but can apply for everything. There's actually a good amount of literature on this. But important to think about the own cultural background. So for example, I was taught and I grew up in a very paternalistic style of healthcare. And my patients would not negotiate, ask, or do anything besides telling me that I would choose and decide for them. When I came here, I learned that that was not the way to practice for everybody. So you have to really adjust to that. And I think that's important. Of course, patients, and if you have young children, parents, cultural identity, and then the role of transference and countertransference. And for that, there are inter-ethnic and intra-ethnic effects. And I'll just mention a few that I think are important. So for transference, mistrust is a big one, as well as denial. And denial can apply for both transference and countertransference when there is no acknowledgement of the influence of cultural factors. In intra-ethnic effects, there can be in transference some ambivalence and actually outer racism, where patient feels that they get inferior care by those who have same ethnicity. And then there's also in countertransference distancing, fear of over-identifying with the patient, ambivalence, anger. Some people actually will distance from seeing patients that are similar to them. And some of this can play a role. But I think being able to recognize this as we see patients who are similar or different from us can be helpful. So after the outline was developed, it had some kind of good initial information, but it was really limited how to turn that into a conceptual framework or a specific interview. There was lack of guidelines on when, whom, and why to implement it. There was need for adaptation, and especially using it in some populations like children, and there were kind of missing topics. So after that, they decided they created a DSM-5 cross-cultural issues subgroup, and they developed the cultural formulation interview. They still keep the 4 domains that we talked about, but now it's more specific. So they have 16-item questionnaire. They have an informant version, so you can actually get collateral information in a culturally sensitive way. And then it has 12 supplementary modules to expand for particular topics and particular populations. So it has been designed to use inpatient, outpatient, emergency, or transitional settings. And the idea is that this broad approach acknowledges that all patients and clinicians come from cultural backgrounds that can affect clinical care, but not assume that culture is only pertinent factor in the care of racial and ethnic minorities. Of course, there is the purpose of the informant version, can help clinicians get collateral information. And when they developed all of this, they actually did a field trial. There were different countries. There was a good amount of people where they tried out the interview. And both patients and clinicians found that the core CFI was feasible, acceptable, and useful. Of course, the results helped them revise the interview until kind of the final one. They believe that the core CFI had communication that was therapeutic patients, and that was independent of clinicians' ability to establish rapport. The kind of the highest barrier reported by clinicians was that they couldn't see how this interview would respond to the need for a culture assessment. And then the second barrier they found for both patients and clinicians was a lack of motivation. And sometimes if you go through the interview, it looks overwhelming because it has a lot of questions. But what I think is helpful is to maybe give it a one-time read and get ideas of ways to approach certain topics, and from there continue to incorporate that into your regular psychiatric interview. So mental disorders defined in relation to cultural, social, and familial norms and values. So that was specific to DSM-5. And understanding that culture provides frameworks that shape the experience and expression of symptoms, signs, and behaviors. Also understand that the boundaries between normality and pathology can vary across cultures. That there are cultural meanings, habits, and traditions that can contribute to stigma or supporting the social and familial response to mental illness. And that is really helpful when we want patients to really adhere to treatment. Culture may provide coping strategies that enhance resilience and of course, response to options for accessing healthcare and following recommendations. Culture may influence acceptance or rejection of a diagnosis and adherence to treatments. And then cultural differences between clinician and the patient have implications in the accuracy and acceptance of diagnosis, as well as for treatment decisions, prognostic considerations, and clinical outcomes. So it's pretty important. And we know that being aware of cultural concepts and being able to have a culturally sensitive practice will help avoid misdiagnosis, improve rapport and engagement, guide clinical research, obtain useful clinical information, improve therapeutic efficacy, and then clarify cultural epidemiology. The DSM not only talks about culture, but it talks about gender differences, saying that sex and gender differences can relate to the cause and expression of medical conditions established for several diseases, including some mental disorders. They use the term gender differences, and they explain that the differences between men and women are a result of both biological sex and individual self-representation. However, some are based only on biological sex. And some of the examples they provide is gender may exclusively determine whether an individual is at risk for a disorder, like premenstrual dysphoric disorder. Gender may moderate the overall risk for developing a disorder, as shown by differences in prevalence and incidence, like for example, anxiety and depression being more prevalent in women. Gender may influence the likelihood that particular symptoms are experienced by an individual. One example is ADHD, and the expression of symptoms in boys versus girls. And some symptoms are more readily endorsed by men or women, and that this contributes to differences in service provision. So women tend to be better at recognizing depression symptoms and kind of seeking help as compared to men. So we're gonna kind of split the interview. We're gonna go through a case so you can kind of see how useful this can be. And then I have some videos where they have examples of how to deliver the cultural formulation interview, or we can talk about some cases that you've had where we can talk about ways that you could have addressed that differently, or we can do a little bit of both. So the first part is the cultural definition of the problem, asking what brings you here today, which is pretty common for any psychiatric interview. But one thing that we often miss to ask is sometimes people have different ways of describing their problem to their families, friends, or others. How would you describe your problem to them? What troubles you the most about your problem? I think that's also very helpful. Then we have the cultural perceptions of cause, context, and support. And that has to do with the cause of the problem. What the patient thinks that's happening to them, and what others thinks about it. Then stressors and support. Support that make things better or worse. Are there stressors that worsen your illness? The role of cultural identity. What are the most important aspects of your background or identity? Are there aspects of your background that make a difference to your problem? Are there any aspects of your background or identity that are causing other concerns or difficulties? So that can be pretty rich when we ask that to patients. Then the cultural factors affecting self-coping and past help seeking. So question 11 about self-coping, 12 about past help seeking. So in the past, what kinds of treatments, help, advice, or healing have you sought for your problem? And then the barriers. Has anything prevented you from getting the help you need? You may already be asking some of these questions in your regular psychiatric interview. Cultural factors affecting current help seeking. So what kinds of help do you think would be most useful to you at this time for your problem? Are there other kinds of help that your family, friends, or other people have suggested would be helpful? And then specific to the clinician-patient relationship. Have you been concerned about this? And is there anything that we can do to provide you with the care you need? Then the informant version, we won't go over the specifics, but it's very similar. It has the kind of the same sections, just specific to the kind of collateral information. Getting someone to talk about that. And then the supplementary material that's part of that, it includes explanatory model, the level of functioning, social network, psychosocial stressors, spirituality, religion, and moral traditions. So that's one I recommend you check out. Cultural identity, coping and help seeking, patient-clinician relationship, school-age children and adolescents, older adults, immigrants and refugees, and caregivers. So there's a lot of additional information, and they highlight questions or modify questions from the core CFI based on this specific populations. Additional resources that you can find on kind of culture. So specific text for specific disorders, cultural variations in prevalence, symptomatology, and associated cultural concepts. I recommend you think about codes V and Z. So I actually use a lot of the acculturation problems code. When I find that there's an issue, there's acculturative stress. Parent-child relational problems or religious or spiritual problems. So I think those are important because when you put those, it helps you really kind of formulate and develop a treatment plan that's different. And then there is a whole appendix of cultural concepts of distress. So there's all the kind of the well-studied concepts of distress, and you can find those in the DSM in case you need that. So I think it does come with a good amount of resources. Any questions or anything before we kind of move on to talking a little bit about the case? Okay. So this is a man, and as we go through the case, I'm going to ask if you have any thoughts or things that you might think could be relevant in the caring for this patient, and then we'll do the sort of the discussion analysis. It's a man in his 8th decade of life with lifelong bipolar disorder. We'll call him Mr. Rodriguez. He meets with outpatient psychiatrist in 2010, and the psychiatrist realizes that the chart included an intake from the 1980s. That first visit, they spoke in Spanish out of patient's preference. Each appointment consisted of 45 minutes of psychotherapy and medication management. He was first seen in primary care clinic and then referred to psychiatry for treatment. The chief complaint was, "I need help." So that first visit, Mr. Rodriguez felt stable and denied symptoms. But in the past, he has had weeks when he sleeps only 1 to 2 hours nightly, feels distracted with racing thoughts, and speaks too fast. When that happens, he listens to music loudly to drown out a voice calling his name, which annoys his neighbors who called their landlord. During these episodes, he also believes that people mocked and target him. 15 years prior to this first presentation, he developed chronic depression after his 2 sons, ages 15 and 22, were murdered in Puerto Rico. He couldn't describe those circumstances, learning about them only after their mother appeared at his doorstep sobbing. Occasionally, he saw their apparitions upon awakening. Notably, the hallucinations and paranoia occurred only with mood symptoms. He's taking valproic acid to 50 milligrams in the morning, 500 at night, perfenazine 4 milligrams every night, benztropine 0.52 twice daily, mirtazapine 30 milligrams at night, and citalopram 10 milligrams every day. No allergies. He has a history of hypertension, type 2 diabetes, coronary artery disease, high cholesterol, COPD, arthritis. And in 1981, he was hospitalized because his feet were crushed by a truck. And in 82, a medical rod was inserted in his left femur, and now he uses a wheelchair. He had been on outpatient care for 30 years in Puerto Rico. He denied previous hospitalizations, suicide attempts, or homicide attempts. He didn't know how his illness started, but he has taken medications chronically in Puerto Rico and the United States. He stopped medications in the mid-1990s because he didn't like taking them. Within weeks, he felt unable to sleep, anxious, and agitated, overly energetic, and able to hear a voice and see the images of his children. He then first presented to our clinic, or to the clinic. From his initial visit until 2005, he took lithium, In 2008, valproic acid was added after lithium was maximized. He also took perfenazine for sensory hallucinations and cogentin for prophylaxis. His substance use history is opaque, denied substance abuse, dependence for detoxification. Though he started smoking cigarettes and drinking sugarcane rum called cañita at the age of 12 upon learning farming. He and his friends drank every day after work until passing out. Consumption increased on weekends and holidays. He estimated drinking 3 American beer bottles during the workday. He didn't recall that alcohol consumption conflicted with work or social responsibilities, nor did he remember withdrawal symptoms. He smoked cigarettes until the mid-1990s when he migrated to the United States. His physician informed about complications from tobacco and he decided to stop drinking as well. Anything else that you want to mention or something that when we think about cultural differences that might matter here?
Do you have any other children, and what's the relationship like with his family members?
Okay, we'll get into that. So that's an important one. The other thing that I'll mention is sometimes the cultural, I would say, acceptance and relationship with alcohol is different. So when I went to do some rural practice in Colombia, I went to a town where it's probably the town where they drink the most amount of beer. They have actually a beer company in the town and everybody drinks. It's a family thing. So on the weekends, they will go out and they drink on this sort of outdoors restaurants, and their babies, children, parents, everybody is drinking. And it's interesting, people will fight with each other, always a bottle involved in the fight. And then after the fight, they all get into the same car and drive to the ED to get sutures. So I really couldn't understand what was going on. Is like, you guys hit each other with a beer bottle and now you're all here together with kids and everybody. But it helped me understand that it's sort of part of that and what my role in educating and in changing that and how much time that was gonna take, right? It was not gonna be an easy thing. The other thing is, although, for example, in Colombia, we shouldn't be drinking before 18, we drink before 18 and it's a little less strict. So parents allow us to drink at home a glass of wine with them. And I've seen it a lot less rigid than, for example, here in the US. And I think it's important to appreciate those differences. I also had a colleague who actually was from France, and she'll actually drink a glass of wine with dinner every night. She was having some problems with sleep and she went, and her primary care provider said that she was an alcoholic. That was back in Boston, and she was so mad that they were saying that she was an alcoholic. And it turns out that actually she was just having a wine like any French person will do with dinner. So I think it's important to think about some of those aspects. Okay. So he was, yeah.
Or tell us about it says sensory hallucinations. Can you tell us about those?
I don't have any more information on those. I'm sorry. So he was born and raised in Puerto Rico. He met all developmental milestones on time, denied any physical, sexual, or emotional abuse. His parents gave him for adoption to a maternal aunt at the age of 3 after moving to the United States with his siblings. He was the youngest of 17 children and doesn't know their details. He saw his father once at 15 years and his mother at 17 years, but had no further contact. He never attended formal schooling. At 12 years old, he started cutting sugarcane with cousins. He worked seasonally as a farmer, construction worker, and brick maker in Puerto Rico. He maintained short relationships of 3 to 5 years with various women, but never married. He didn't know how his only 2 children were murdered. He considered himself a Pentecostal. He had no history of legal problems. He moved to the United States a few weeks prior to presenting to our clinic to follow his girlfriend. He stayed with her and her son for 2 years before she ended their relationship. Soon after, he informed his primary therapist about his homelessness and has since lived in an assisted living facility for Spanish monolingual patients. And if you're wondering, this case comes from one of the biggest contributors to the cultural formulation interview from Colombia. So this is in New York. So I don't think we have a Spanish monolingual facility here. So he had no sustained contact with siblings or parents. So he didn't know about psychiatric or substance disorders. He denied such history in extended relatives. Mr. Rodriguez was a well-dressed man who sat in a wheelchair and appeared comfortable. He was pleasant, cooperative throughout the interview. He described his mood as happy and his affect was full range. His speech was spontaneous, fluent, and goal-directed. His thought processes were linear and coherent with intact associations. He denied hallucinations, delusions, or other psychotic phenomena. He denied suicidal and homicidal thoughts. There was no impulsivity. He had great insight and judgment, recognizing that he needed medications to live as desired. He was formulated as having bipolar 1 disorder, most recent episode manic, severe with psychotic features, alcohol abuse in full sustained remission, and the question about alcoholic dementia. Then all the medical comorbidities we talked about, and then educational problems, occupational problems, and economic problems. And I think adding educational problems is very important. Any thoughts about kind of the role of culture or how, or any challenge that you would anticipate when seeing this patient? Starting, I would sort of say that language might be a barrier to begin with.
Sounds like there'll be financial barriers, and then just lack of social support in the States.
So the social, the social support, and then the financial.
For sure. I should say continental states.
Anything else? Do you, so he's been in the US maybe roughly 15 years, but really all his life in Puerto Rico. Do you think, if you think about him as his kind of acculturation process, or do you want to know more of his, what is his cultural identity? Does he connect with Americans and American kind of lifestyle, or is he very much into his kind of Puerto Rican? And I think it's important because he's in a monolingual Spanish nursing home. So if he were to move to a different state, or that place closes, or he needs a new placement, you need to be able to know that to help place this patient in a hopefully in a home that would adjust to those cultural needs. So let's do a little bit of the discussion. So in terms of cultural identity, so Mr. Rodriguez identified as a Spanish-speaking Puerto Rican. He felt connected to this cultural group and lived in an assisted living predominantly for Spanish-speaking residents. He and his parents shared the same cultural background, and all ex-girlfriends were Puerto Rican. And I think that's actually important. I've seen patients or even friends and colleagues who move, and they never, even 30 plus years, they will never date someone who's not from the same background. And sometimes that's important to explore and to keep in mind. Mr. Rodriguez spoke only Spanish as a child. He spoke Spanish exclusively and only established care at medical facilities with Spanish communicating staff. He could not read or write Spanish and didn't know another language. In English, he only exchanged pleasantries such as hello and goodbye. So this would be, for example, very important and relevant if you do case management, and it has happened to me with the Spanish-speaking families. If the case manager does not speak Spanish, is really problematic. Because a lot of the calls, for example, to the county, a lot of the services that you request, a lot of the forms you have to fill out, you want to have the family understand that. And I found that can be a really huge barrier. Cultural factors in development. So his biological parents placed him with relatives upon migrating to the United States. He learned farming and construction through older male cousins. His independence within a network of extended relatives might explain a lack of curiosity about his nuclear family. He might have also harbored anger and resentment at abandonment. And I've actually seen that with some of the children and that are left aside when parents migrate. There can be a lot of that, even for parents who bring them without their consent. Traditional gender roles appear prominent given his emphasis on manual labor, preference for male friends, and fleeting connections with women. Mr. Rodriguez participated in his culture of origin by consuming Puerto Rican music and watching Spanish language media. He practiced Pentecostal Christianity and went to church daily in his facility with Puerto Ricans. He celebrated Puerto Rican holidays and ate Puerto Rican food daily prepared in his facility. He was very lucky. Illiteracy prevented him from reading newspaper, magazines, or the internet. So news came from his best friend and other assisted living residents. He missed his independence in Puerto Rico. His limited mobility and finances prevented him to visit since migrating. His involvement with his host culture was superficial. He didn't associate with English speakers and limited interactions to those speaking Spanish. He didn't follow American media, entertainment, news, or holidays. He liked American desserts such as cookies, but didn't eat other American foods. That can also be a problem, for example, when you hospitalize. And of course, I think Mayo has some more variety of foods when you have people inpatient, but I've encountered some barriers with patients who want to, adhere to their religious practices while inpatient, or have their families bring some food. And some of that might be really important for them. And we sometimes don't pay much attention to those details. And I think that can impact their relationship with the team and then the outcome. He actually called it the problem he had insomnia. He didn't remember the first time he fell ill. He had no other name for the illness, no explanation about its mechanism, treatment, or prognosis. And he deferred to physicians entirely. So he was used to that paternalistic care. He only visited biomedical professionals for the problem and not other healers. He didn't know others with insomnia. His illness caused distress in several ways. When he had too much energy, he stayed awake in bed. To slow his thoughts, he listened to music loudly, angering neighbors. His medications bothered him. The antidepressant caused stomach acidity, and the antipsychotic caused involuntary tongue movements that obstructed his speech and digestion. However, he understood that medications controlled his symptoms. So in the third area about factors related to psychosocial, so stressors, he denied that stressful situations or events worsened his illness. He described his symptoms to physicians, but not to his community. He was sensitive to alcohol's potential role and didn't want friends to judge him since he now attends church regularly. Supports, he felt most comfortable discussing healthcare with a best friend who served as his greatest emotional support. So I think Julie had mentioned about his supports. He had one friend. This friend attended every appointment and he wanted him to be part of the care. He denied having any other supports. His living facility arranged daily needs, and he only went to church services and medical appointments. He found it difficult to eat and swallow from the tongue movements, and he had not worked in over 25 years. So the elements of the clinician-patient relationship, Mr. Rodriguez and the provider spoke in Spanish. The psychiatrist introduced himself as a physician who studied Spanish and volunteered in Hispanic clinics in medical school. He emphasized that his fluency may occasionally be limited and that he may ask for clarification or turn to a dictionary. And I will comment that when I see someone, unless I know that the patient is a non-English speaker, I would never assume they want to speak in Spanish. So I always will come in and ask them if they have a preference, that I speak both languages and I'm comfortable in either. And I have many times where patients prefer English. So I think this is something important. You wanna also be able to speak the language well enough so the patient is comfortable. Mr. Rodriguez initially explained thoughts and feelings slowly, but stopped within a month after feeling comfortable with provider's fluency. There was a filial transfer emerging because he started referring to the psychiatrist as child. He also used the informal tú rather than the formal usted to address kind of the psychiatrist. And I think that's very common. It also varies even within the country. So when I practice back home in Bogota, usted is a very common way to refer to older people, to patients, it's a respectful way. When I practice in the Caribbean coast, people tend to be warmer and kind of closer. So they will say tú all the time. You can decide how much boundaries you want to set. But I think if you are familiar with the culture, and I've noticed here that people use more in Spanish tú rather than usted, and I feel comfortable with that overall. So the overall assessment. So the cultural formulation interview delivered useful information beyond a standard assessment. Through the cultural identity, Mr. Rodriguez surfaced as a man who identified intensely as a Puerto Rican, despite living in the United States for over 15 years. However, he learned to negotiate social services by receiving steady housing and treatment. Through cultural explanation of illness, he changed his mind from being clinically stable to wanting treatment for side effects. He didn't retain a separate understanding of his illness and deferred all the care to physicians. With the cultural factors related to psychosocial support and level of functioning, Mr. Rodriguez expressed hope for his best friend to be included in treatment.
Hi, my name is Dr. Agarwal, and I'm one of the psychiatrists who's been working with the team that's caring for you right now. What's your name?
My name is Yvette.
Yvette? May I call you Yvette?
Sure.
Your team asked me to speak with you because they felt that by asking you some questions, they may be able to provide you with better care. So I want to understand your experiences and viewpoints about what's been going on with you. There are no right or wrong answers, and it won't take all that much time, if that's okay.
Okay.
Thank you. What brings you here today?
I came because of my lungs, but let me get this. Did you say you were a psychiatrist?
Yes, I am.
What does that have to do with my lungs?
Well, I don't quite know yet, but maybe in asking you these questions, we can figure out what it may have to do with your lungs.
I came here because of my lungs.
Uh-huh. And your lungs.
That's it.
Sometimes people describe their problems in ways that may be similar or different to the ways that doctors describe them. How would you describe your problem if you weren't talking to a physician, maybe?
Is your lungs connected to your head?
Is your lungs connected to your head?
Mm-hmm.
Yes, it can be. Through different parts of hormones and other kinds of neural connections.
Well, I came in because of my lungs, not because of nothing that's going on up here.
Okay. And sometimes people describe their problems in different ways that they're talking to people in their community, like their friends, family, or other close associates. How would you describe your problem to them?
I can't breathe. I smoke. I have a problem with my lungs.
You can't breathe, you smoke, you have a problem with your lungs. Uh-huh. How do you understand what's been going on with you around not being able to breathe?
I just can't breathe. It's because of the smoking.
It's because of the smoking? So you see that there's a connection there?
Yeah, but it has nothing to do with me needing to see a psychiatrist.
Uh-huh. So it sounds as if they've asked me to see you without you knowing about that.
Uh-huh.
Mm-hmm. And what did you know about problems breathing and maybe a connection to smoking before it's starting to affect you today?
Listen, my husband smoked. Came into the hospital, same reason, he never left. They killed him.
Mm-hmm. So it sounds as if you're telling me that maybe another problem is that you're worried about not being able to leave the hospital.
I just want to go home. I just came in to get something so I could breathe better, so I could go home.
Mm-hmm.
And now all of a sudden I'm seeing you.
Mm-hmm.
All because I refused to take a test.
Has anything like this ever happened to you at all?
No, because every time I come to the hospital and they want to, I come in for a problem with my lungs, they want to run a problem, run my legs, test this, test that, I always leave.
Mm-hmm. And you mentioned that something similar like this happened to your husband.
Yes.
Uh-huh. And can you tell us a little bit more about that?
He came into the hospital, he had a problem breathing, he came into the hospital, they killed him. And they took his lungs, and they took his heart, and they took everything else. And they run tests on him, all sorts of tests, the same kind of tests I hear them mentioning to me. So you know what? That means they want to kill me.
So you're afraid that's going to happen to you?
I know what's going to happen if I stay. That's why I want to go home.
How did they kill him?
They killed him with all that test.
How do they kill them with the tests?
It wasn't necessary.
Uh-huh. Was there something about the tests, or was it about the time spent in the hospital?
It's all of it, all of it, all of it.
Mhm. Have you ever read anything or maybe seen anything about this, whether it's on the TV or the radio, the internet, about people not being able to leave the hospital because of
About
tests?
people coming in and getting tested and getting killed.
Mhm. What troubles you most about this?
You killing me.
You think that we would kill you?
Mhm.
And is that based on your experience with your husband or any other kinds of?
It's based on that.
Mhm.
Any kind of thoughts? Too old, or where is this? Oh, this one.
He sure didn't validate her concerns.
Yeah. Yeah, he never said that. That would probably never happen. But it was interesting how it sort of evolved, and the real problem was her fear and mistrust, right, of the system and the care. That was important to know. We'll do another one and we'll talk about this one. This one has other examples of kind of questions that way they.
Where were your parents and grandparents born?
They were all from Panama. Well, on my mom's side. On my dad's side, they're American.
How would you describe your family's national, racial, and ethnic background?
Well, on my mom's side, I mean, my mom is a citizen now, but she came from Panama. And my dad is white from America. So, I mean, I guess I would call myself American, but I mean, there's a lot of, traditions and culture that I carry with me from the Panamanian side of my family.
In terms of your background, how do you usually describe yourself to people outside your community?
Well, I tell them I'm Hispanic, and then if they want to know more, I'm like, okay, my mom is from Panama, and my dad is from the U.S. I mean, it gets kind of confusing when you talk about Hispanic because, people can be a mix of anything. They can be a mix of black or white or Native American and everything. So sometimes people get confused about it, so I just don't. I try not to just even enter those topics.
Sometimes people describe themselves somewhat differently to members of their own community. How do you describe yourself to them?
Really, I just feel like any other American person growing up in my hometown. But if they really want to know, I tell them a little bit about the Panamanian side of my family. My mom immigrated from Panama. We have a lot of the cultures still in my household. The food and we're really close in my family and things like that.
Which part of your background do you feel closest to?
I have to say that I feel closer to my family from Panama. I've traveled there sometimes when I was little, and I would always love spending time with my grandmother there, and I felt so close to her. And I love, being in the countryside there with her, so that's something that's very dear to me.
Those were a few examples of how they kind of practice or some of the questions of the interview, and some additional information you can get from just digging a little bit into that cultural ethnic background. Okay. Yeah, I had it at the 3:30. That's why I was confused.
Okay.
Well, thank you guys. Any questions or anything for us, you can send us an email, but we'll see you guys next week for the second part.
Next week. Yes. Well, part 2, looking at mental health equity and managing microaggressions in therapeutic spaces. So if you want to get your head start thinking about that or come up with some good questions, we'll probably try to have some good discussions. Thank you. We give you about 12 minutes back.
Thank
Have
you.
a great afternoon.